Well, as the title clearly demonstrates, the goal of tonight's discussion is about trigeminal autonomic cephalgias, or as we call TACs. And they're a unique group of headache disorders. And I hope that through this evening, I can shed some light through the diagnostic criteria, the treatment, some of the workup and evaluation, and trending directions. So without further ado, we'll go ahead and get started. I have no disclosures, just for interest's sake. My name is Susan Baggaley. I'm a nurse practitioner at the University of Utah. I'm the division chief for the Division of Headache and Neuro-Ophthalmology in the Department of Neurology. Have been in the department for about 30 years. I've been seeing patients with chronic migraine, cluster, and other headache disorders for many years, and really happy to be on tonight to give what I think is hopefully a useful and updated talk. So I think it's always important when we look at diagnostic criteria that we review the source of which we use for the classification of headache disorders. This was the most recent journal that was published in what's called Cephalgia regarding the international classification, or the ICHD-3, for all headache disorders. The link is within this talk, and also easy to Google if you have further questions about reading it and looking at some of the things we're going to talk about tonight. I think the main issue that's bearing weight is that we have classifications of headache disorders. So we discuss things like primary headache disorders, which are essentially, we would say, benign, not to the patient clearly, because pain is not benign, but without other underpinning or reasons for cause. So migraine, for instance, is a primary headache disorder. Tension type headaches and the trigeminal autonomic cephalgias also fall within that category. And these are just a few to name. The secondary headache disorders are the ones we think of, red flag or other underlying disorders creating the headache itself. So a brain tumor, obviously, high or low pressure headaches, something called temporal arteritis, which occurs typically later in life as a unilateral painful phenomenon. Certainly subarachnoid hemorrhage or blood in the brain, worst headache of one's life, is also what we would consider secondary headache disorders. That's just a very small snapshot of what we would talk about in secondary headache disorders. But the PDF of the ICHD-3 has multiple of which to read through. But when we classify TACs, and the discussion tonight is held mainly to these headache types, one being paroxysmal hemicrania, another hemicrania continua, the ones that we refer to as short-lasting unilateral neuralgiform headache attacks with conjunctival tearing and injection. And the separation between the SUNCT and the fourth headache type, SUNA, just is that SUNCT always has tearing and redness, whereas SUNA just has one autonomic feature. And lastly, we'll talk about cluster headaches. I spoke about cluster headaches and the TACs a few years ago, and I realized that I started out with cluster, so I thought I'd end this talk today with cluster. So I think the main component that we talk about when, as a clinician, seeing a patient for the first time with presentation that's not typical, is we always want to make sure what these headaches are not, and why we want to think about a more thorough workup when they're first being evaluated. Because secondary headache types like trigeminal neuralgia or vessel disruption like a dissection or an aneurysm, again, tumors, things like infection, herpes infection that may be right at the eye, and so you might get some of these features that look like a TAC, or post-traumatic. So if people can have facial injuries and give them an underpinning of a new headache diagnosis that's trauma-related, but can still give some of these autonomic features. And then certainly even dental issues can come up, impacted or infected teeth, can also present themselves within this trigeminal face of other headache types. So again, typically speaking, if I'm seeing somebody for the first time with a new diagnosis and a new symptom of one-sided headaches, they're likely going to get a little bit further in the workup than somebody who presents with a typical fashion migraine with family history and no red flag symptoms. So without further ado, just to start with the diagnostic criteria. So paroxysmal hemicrania, and we have this bullet point just for the sake of what's in the journal, saying that the patient should have at least 20 attacks with these features. And part of that, again, is in the workup, or if we're looking for research or other purposes, you want to make sure that this isn't the first time they've had the event and they get diagnosed with something that they actually may not have, as I mentioned earlier. So typically it's a very severe one-sided or unilateral around the orbit, above the eye, or even temporal pain. It can last 2 minutes to 30 minutes. And as we go through the different types of headache with the TACs, what you'll see most often is the differentiator is how long the attacks are lasting. Patients can have an attack any from 1 to 40 times in a day. And you can see that can, in some episodes, consume somebody pretty much the entire day. They also have to have either or both of the following, meaning at least one symptom that's the same side as the headache. They have to have injection or redness, tearing. They may have nasal congestion or runny nose. They could have eyelid edema or puffiness. They might have forehead and facial sweating. And they may have miosis and ptosis, which means a smaller pupil and a droopy lid. And then the second thing that should come with this is a sense of restlessness or agitation. But what you can see is in that diagnostic criteria, somebody may actually not have a true autonomic feature, but they have these episodes of pain that come with restlessness and agitation. So typically, because they're in the autonomic family, we would expect to see some feature, but just as a disclaimer within the criteria, it doesn't have to be there. Can happen greater than 5 times a day. It's that sharp throbbing. Interestingly, in this type of headache, it can occur from a trigger of alcohol or nitroglycerin, for instance. It's not quite common, 1 in 50,000. The gender ratio is equal, though I would say clinical presentation, I feel like I see more women with paroxysmal hemicrania than men. And when we think about the differential diagnosis, even in the TACs, when we think of a female predominant headache, probably more paroxysmal hemicrania, and a more male predominant TAC, that would be cluster. But again, this is about a 100% responsive headache to indomethacin, the anti-inflammatory that's very specific to these headache features. And also, we always have a disclaimer that this is not better accounted by any other diagnostics. We typically treat paroxysmal hemicrania with indomethacin, as I had mentioned. We start low with 25 milligrams 3 times a day. And then if they're tolerating, then they go up to 75 milligrams up to twice daily. The caveats behind using a potent non-steroidal like indomethacin is you have to know if your kidney clearance and kidney function is normal, you haven't had a history, say, of a gastric bypass, you don't have any other problems with gastric bleeding, because that is something that's very specific to that class of drug. If you can't take that, then other options may be a medication called verapamil. Topiramate is an anti-seizure medication, sometimes nerve blocks. Sometimes we use other things like gabapentin. But historically speaking, when you're trying to get the diagnostic criteria correct, and if you're thinking, it sounds a little bit like cluster, but it's very short, it seems to be a female, indomethacin is a pretty quick and easy way to test the water in that treatment plan. So that's in a nutshell, sharp, stabbing, throbbing pains around the eye with agitation and some other feature perhaps of autonomic symptoms. Now, the other side of the coin is what we call hemicrania continua, which means it can be anywhere from 20 minutes to lasting several days. And so what happens with this is it's still a one-sided headache, can be constant, but they too have some of the features with what was described in Hemicrania continua. So it's almost as if the paroxysmal hemicrania morphs into a more steady state headache that doesn't have those big spikes and drops, but more of this constant moderate to severe pain. And even in the Hemicrania continua world, you might find that they have some migraine features as well. And unlike paroxysmal hemicrania, doesn't seem to have any precipitating factors around it. But again, this is another diagnosis that is typically 100% responsive to the indomethacin class of drug. Okay, as we move on, we talk about the next two headache types, which are the short-lasting unilateral neuralgiform headache attack. The first one we're going to talk about is SUNCT. And the reason that's important is the very last two letters of SUNCT is conjunctival tearing. So again, moderate and severe. These are not patients who are very comfortable, I can tell you. And if you're one that experiences any of these headache types, they are a different caliber of pain. Migraine pain certainly is intense and disabling, but these TACs also come with other features, can be pretty disruptive. In the SUNCT and diagnosis, you can have a duration of anywhere from 1 to 600 seconds. You can have single series. You can have a little bleep like this. You might have a static bleep. You could get into a sawtooth where it's just up and down, up and down, up and down for several seconds, and then it remits. But what must be present is that the injection or redness and the tearing of the eye that's on the same side of the pain has to be present for this diagnosis. And again, it can occur at least once a day, but anywhere from 3 to 200 times per day. So again, a feature that's short, brief, not lasting into the 15 to 30-minute realm, but maximum about 10 minutes if you look at that 600-second diagnostic criteria. These are actually not responsive to the indomethacin, as we see more in the sodium channel effects that we use a drug called lamotrigine, which is an anti-seizure drug, is probably our first line that we would look at. Then topiramate, gabapentin, also anti-seizure drugs. In some instances, IV lidocaine can be the treatment and respite for this disorder. With IV lidocaine, there's very few places. Our colleagues in the pain clinic do have this service, but you also have to be aware of no underlying history of any cardiac arrhythmias, so funny heartbeats, or history of seizures. So there's some pretty limited criteria to get the IV lidocaine, but it can be very useful. Also, a greater occipital nerve block on the same side of the pain has shown to have some benefit, as described by Cohen at the Migraine Trust Foundation. So that's what we refer to as SUNCT. And then we move on to the next one, which is SUNA. And so it's another short unilateral neuralgiform headache, but very interestingly, again, typically around the eye, can be short in anywhere from 1 and probably not even more than 240 seconds. I think I need to correct that one. And it only has to have one autonomic feature. So unlike SUNCT that has to have the redness and the tearing, this just needs to have either or one of the other features of autonomic dysfunction: congestion, runny nose, puffy eye. So similar in those other diagnostic criteria of the autonomic. Again, typically seeing that it happens at least once a day, but most often these are people who have a lot higher frequency than one episode a day if they're going to come and see you for evaluation and treatment. Just as the SUNCT headaches respond to lamotrigine, the SUNA headaches similar, but there's been also some discovery with oxcarbazepine, which is a sister drug to Tegretol or carbamazepine, and then duloxetine, which is in the serotonin norepinephrine reuptake family, can also have some benefit, as does IV lidocaine, with the previous caveats that I mentioned. Okay. Then the next big topic. So those are the first kind of nuts and bolts of the trigeminal autonomic cephalgias that are not within the cluster diagnosis. I know there's a couple of people online. I just want to check to see if there's anything in the chat, in case anyone has a question before I move on. And we look like we're okay. All right. So cluster headache. Oops. I think probably the biggest feature when we talk about cluster is you'll see the bottom part of the slide where it says suicide headache. I would like to say that this is the headache that makes me as a clinician in 35 plus years the most anxious about the safety of my patients. And because of the severity and the intensity, these are what I feel like not just desperate people looking for help, but often have a hard time getting to the right diagnosis. So it typically is anywhere between 4 to 7 different clinicians that a patient may be evaluated before they're actually given the formal diagnosis of cluster. I think we've improved in that realm, maybe from social media standpoint. People who have clusters, somebody like Arnold Schwarzenegger, for instance, has cluster. So sometimes when there's a little bit of social attention to something, everybody gets to be a little more enlightened. And I think in some ways that's okay, right? But this is a severe or very severe one-sided headache, again, usually in the orbit around the eye or temple. And you'll see the duration of this, anywhere from a 15-minute episode up to an entire 3 hours, especially when untreated, the severity. And then that can happen up to 8 times in a day. So it's pretty tragic if somebody gets into a point where they have zero respite or they don't have something to manage this pain. They're pacing and they're super uncomfortable. Why this may lead someone to think about the alternative of ending their life. But along with this pain, they also have to have, and generally speaking, these are the restless people. So you think of oftentimes a migrainer who wants to maybe go to bed, turn the lights off, lay down and be quiet. This is somebody who's going to pace. They may take a hot shower. They're going to do things to help the distraction and find some way to help that feeling. But they typically still have the symptoms on the same side of their head. They get the injection and or the tearing. They may have congestion or runny nose. So eyelid edema or swelling, sweating in the face and head, and the change of the pupil. And I'll have some pictures in a minute to show you. But again, you can see how some of these diagnoses have such similarities and overlapping that we're really struggling in some instances if a patient can't give a very strong history, why we're trying to tease out everything in between the story so that we can make sure therapy is appropriate, because as we've already demonstrated in the first 4 types of headache, they have different responses to different medications. So again, we think of cluster, the prevalence is about 240 per 100,000. And typically male predominant. Triggers might be smoking, alcohol. Typically we talk about seasonality. So meaning, is it spring or fall that they can get their cluster cycles? Those are episodic cluster cycles if they break, but if they're chronic, they just continue through. As mentioned previously, up to 8 times a day with an episode of 15 minutes to 3 hours. Sometimes they may have a feature that their headache attack occurs 1 to 2 hours just after going to bed. That may be the precursor of what's yet to come. So that's the other thing, is kind of seeing what that circadian rhythm has to do with it. And also because the hypothalamus is really a part of our brain that's the body's biologic clock. And so what it says is that if it's overactive, and we think about the hypothalamus secreting melatonin and serotonin, and so trying to de and downregulate the hypothalamus is also part of the therapy. I mentioned earlier the pacing or the hot showers or the differentiation of the migraine or going to bed more often. And then we look at the duration of cycles. So cluster can be episodic, can be 2 weeks up to 3 months. And it can have a separation period of time with at least 3 months in between of a break, whereas chronic cluster occurs for at least 1 year or longer without any remissions or remissions less than 3 months. So probably 80% of the patient population is actually experiencing episodic cluster. And when we talk about what is triggering this, so the hypothalamus is part of the brain that we think releases both histamine, which can cause that flushing in the face, may explain also some of the other autonomic cephalgias. And they actually trigger and activate this nerve pathway in the back of the brain called the trigeminal autonomic reflex. And that's what causes the pain and these other symptoms that come to one side. But we do blame the trigeminal nerve as the main nerve in the face that's responsible for this. So we break out the trigeminal nerve into 3 parts in the face: the first division, second division, and third division. And that is the area that affects facial pain. And again, when we're sorting out between, is this a cluster or a trigeminal autonomic cephalgia, or is this something like trigeminal neuralgia? The difference with trigeminal neuralgia is oftentimes it doesn't come with autonomic features. It has a different characteristic altogether. More of an electric, sharp shooting pain rather than an intense throbbing pain. And because of this activation in the trigeminal nerve, what you can see here is the droopy lid, the runny eye, the runny nose, affects those ophthalmic branches coming off the trigeminal nerve. It can go into the jaw, but not very often. But it's why we think of this mechanism being the major underlier for cluster activation. And here's a picture that also demonstrates what we call a Horner syndrome, where the pupil's just a little bit smaller, the lid's just a little more droopy, and that comes with the pain. It also typically resolves when the pain goes away. So it is interesting how you have these other disruptions within the mechanisms in the brain and the cranial nerves that can happen episodically and remit. And as I said earlier, who gets cluster? Well, typically men are 4 times more likely than women, but it doesn't discount the fact when you're getting a history or you're giving the history as a patient, how frequent, how long the episodes are lasting. And we rely heavily on you as the patient to also give us as much information about the episodes so we can really formulate and articulate the plan. We know that alcohol, as I mentioned, can also be at risk for cluster headaches. Family history, there may be some genetic predisposition to get cluster within the family as well. We see that frequently in migraine, but because cluster is not very common, it's something that we want to know about if it runs in the family. And then we talk about what to do when one gets a cluster. So the typical way to abort a cluster is with high flow oxygen with a non-rebreather mask. So in the few of these demonstrations here and the pictures, this is what a typical non-rebreather mask looks like. It has the bag on it. You never want to be given nasal cannula because we use high flow, 15 liters, anywhere between 10 to 15 liters at about 10 to 15 minutes. And so there's no way that you're going to sustain having any amount of that flow going through nasal cannula. It's not going to deliver it the same way as the oxygen mask. I also wanted to share the Cluster O2 kit because this is out of the support group from Cluster Busters, and that's a website at the end of the talk that's on your slide deck as well. But this is another delivery device for 100% oxygen delivery as well. The tough thing, of course, is many insurance companies don't cover the oxygen for cluster. I think we're still fighting the battle every time we go to Headache on the Hill, which is coming up in February or March this year. It's another point of discussion to try and force the issue with what treatments work and when we're up against a wall with insurances. Sometimes patients will have a few of this, or I'll write a prescription for them to get maybe 6 of the E cylinders. They're the about 3 feet tall, maybe 8 inches, 6 inches in diameter. Just so they have something if they need to be portable. The M90 is a big tank they can have at home. It does seem like the other oxygen concentrating machines can't quite get to a level of 100% delivery. And so they may not be providing as much oxygen delivery as the bigger M90 tanks or the E cylinders with a regulator that you can control. Beyond oxygen, triptans have probably the most amount of research that's been done on them for approval and treatment of cluster. So sumatriptan injection used to only be a 6 milligram dose, and you could only have 2 doses in 24 hours, which if you have more than one cycle, the rub is that you're sort of at maximum capacity. But now we have 3, 4, and 6 milligram doses of sumatriptan, so that may be another way to augment a severe breakthrough cluster day for patients. The sumatriptan nasal spray is also an option. Kind of, if you think about nose to the toes and a gentle sniff, because you want to really deliver it up in this area. If you inhale too hard, you'll end up with this in your throat, and it's terrible tasting. You can mix a sumatriptan injection, no more than a total of 6 milligrams in a day, with a sumatriptan nasal spray, and they come as 5 milligrams and 20 milligrams. But the max total is 40 milligrams of sumatriptan nasal spray, or 12 milligrams of injection, or half thereby of each. Zolmitriptan nasal spray comes as another opportunity for rescue. Sometimes it just depends on what insurance companies will authorize, but it also cannot be used in concert with the other triptans. So there's no mixing and matching of different drug of triptans, but you can use sumatriptan injection and sumatriptan nasal in the same day. We talk about steroids kind of from an abortive standpoint, that if somebody's been in a refractory cluster cycle, then we will use a high dose of a burst and taper. So it's not basically therapeutic, if you will, to get a Medrol dose pack. They're not big enough as far as the dosage, and they don't last long enough. So typically people, if we're going to use a cluster pack, we'll do like 80 milligrams of prednisone for 4 to 5 days, and then 60 milligrams for 4 to 5 days, and so on down to the point where they're finally off it. So it may be 20 to 30 days of being on a steroid, which we also try to avoid if we can, mainly because of the side effects of a chronic steroid. You might get some moon face, you might get agitation, and they're already agitated already. And sometimes people get more of like the steroid rage. So we have to be really thoughtful about that. Other things that we can do to try and block and break a cycle is maybe an occipital nerve block. And then this lower picture of this gentleman that's holding the gamma core, or the vagus nerve stimulator, was also approved for aborting cluster headaches, and also in the prevention for them. So there are some things when we're trying to eliminate the headache when it comes on, versus what we're trying to do in the big picture is really how do we try and prevent clusters from happening or from being more escalating and causing more trouble with quality of life. So verapamil is still, I would say, most often the mainstay go-to first-line treatment, anywhere 120 milligrams to 360. Some people really push that higher, but you have to worry about side effects like constipation, heart block, and some other things. Lithium has also been studied as an effective treatment, Class B evidence for cluster. Again, I mentioned the nerve blocks. Melatonin, we talk about that superior hypothalamus release. So adding melatonin, especially because it's a nighttime circadian rhythm, up to 10 milligrams nightly. In addition to that, we'll sometimes add a tricyclic antidepressant like amitriptyline, because the tricyclics help in chronic pain, but also help in that sedation to hopefully see if we can get you to sleep through that cycle as well. And then really the FDA approved the CGRP monoclonal for episodic cluster, galcanezumab, in 2021. And it's a 300 milligram dose. It's 3 separate syringes that one gives themselves every 30 days during the cycle. And really in the study that was, the pivotal trial to say, is this working? You can imagine we don't have that many patients that have cluster. So there was a chronic cluster trial and the episodic cluster trial. The chronic cluster trial just didn't reach what we call primary endpoint, and likely because of the enrollment criteria and the difficulty of which patients have to keep diaries. So there just wasn't a number high enough to treat to break out between placebo. Fortunately, in the episodic cluster trial, there were still only 49 patients, I think it was, in the active trial and 50 or so in the placebo trial, but enough that helped break out the variance of the duration of the episodes and the attacks per day whilst they were having an episode or a cycle. And so this has been one of the newest therapies we've had in the last couple of years to add to the armamentarium of treating and preventing cluster. And this is just a little cartoon that shows where CGRP is released in the vascular blood flow. And it's also been found to be elevated, just like we see elevations of CGRP or calcitonin-related peptide. Basically, it's a protein that elevates also in migraine, but we also see it elevated in cluster. In fact, when patients were in active cycles, there was a study that showed the tiers of one in cluster having a high level of CGRP as well, as long as it had not been aborted or treated with medication. So CGRP definitely plays a role in this world. And then we also think about invasive therapies. And again, the minute we have to step away from traditional, more conservative medication regimes, there may come other risks and things that happen with surgeries. An occipital nerve implant or a stimulator, they have been studied. For some people, it may be useful. Sometimes a little lesser invasiveness is a sphenopalatine ganglion block, which essentially is lidocaine up the nose with your head back and usually delivered through a medication delivery device to get to that area to block it. Deep brain stimulator, so that's definitely neurosurgery, right? And there are some reports in the literature where this has been helpful, but again, these were probably reserved for the most severe of cases between the occipital stimulator placement and the deep brain stimulator, whereas a sphenopalatine block can actually be done in the office as a trial. I would be remiss if I didn't at least sort of finish some of this conversation with the research that's been done with cluster headaches and psilocybins. So this was published in, I think, November 22 last year, which was Dr. Schindler's group, who has probably spent the most time at Yale looking at the possibility of benefit with both from microdosing and different dosing of psilocybins with clusters. At the end of the day, the research still tells us they didn't probably have enough patients in this trial to give complete and maybe deliverable metrics to say that this works or this doesn't work. But I think what it did is it sparked a lot of attention to the gravity of this diagnosis, and not that this is snake oil or looking for something just out there in the universe, but in older times, they used psilocybins for other pain. And even, as we know, research now is being done actively in PTSD and other things. And other diagnoses. So there was that article that was in Headache. I do and would point you to the National Library of Medicine, that if you Google clinicaltrials.gov, you can just enter cluster headache, and then that will pop up any studies that are currently involved with research. So this one that I pulled up was the prophylactic effects of psilocybin on chronic cluster. And as you can see over on this column, the study start actually was January of 2020. And what do we know happened in 2020? We had a pandemic. So they only got to 10 total patients, and the study was stopped because there was not enough patients to enroll to come together with basically a good outcome or ability to measure the benefits. So I think this will probably still recycle in the world of when we're looking at cluster, we're looking at psilocybins, there'll be more of this on the horizon. But again, clinicaltrials.gov is a great website to go to and see what else is out there in the study of, well, really any disorder, but specifically in cluster psilocybins and other headaches. And then, as I mentioned, this is the website to refresh your memory if you want to look at very articulate descriptions of each diagnostic criteria for every headache type. I had mentioned that the clusterbuster.org is a website, and they are frequently updating it. There's several blogs that are out there, but I think it's always good to know, the resources and what's being recommended. The Migraine Foundation and American Foundation for Headache also have updates on their websites. So if there's anything else that seems to be of curious information and you want to have, what I say is the double click to make sure what the first line says in a sentence versus what's behind that first line in the sentence. So with that, that's pretty much covering the trigeminal autonomic cephalgias for the evening, and the treatment and the criteria for diagnosis.